We've had some amazing scientific talks earlier in the morning, and so I just want everyone to sort of relax after you've enjoyed your lunch. And, you know, I'm really going to tell more of a story, I think. When Brad asked me to do this talk, I thought, oh yeah, that'll be no big deal. But then when I really started going through all of the things that our patients have gone through during COVID, it really was amazing at what we have actually endured, what our patients have endured, and how we have been able to continue the fight for our patients. So what we're going to review are a couple of things: the impact of COVID on the delivery of care to cancer patients, the adverse outcomes of our cancer patients, delays in diagnosis, disruption to research, and then what the future holds. I think this slide off social media really says a lot. This is what our patients were really struggling with. They were afraid to come out because they knew they were likely at higher risk due to suppressed immune systems. But they also wanted to go on with their treatment because they know that cancer did not wait. So starting off with a question, during the COVID pandemic, what % of cancer patients had a disruption in their care? I think most people are assuming probably around 50 to 60% of patients, but actually it was greater than 79% of patients. As you can imagine, the American Cancer Society has been keeping a very close eye on what's happening to cancer patients during this pandemic. And they did a survey in May of 2020. So remember, it was basically March of 2020 that the pandemic was recognized, I guess for lack of a better word, and we really started shutting things down. In May, 79% of active cancer treatments had a disruption in their care. Just 1 month before, it was only 27%. So you can really see the difference in the environment as things shut down. Those delays caused a ripple effect, and it was not only leading to potentially worse outcomes, but also causing other concerns. But why were they delayed? Because they stayed home? What was it actually? Well, there really kind of were two big categories: medical and financial reasons. Actual surgeries were delayed because for some unclear reason, our cancer patient surgeries were considered elective. And as you know, all elective surgeries were stopped to keep the ICUs available for patients with COVID. Radiation was delayed, chemotherapy was delayed, hormone therapy was delayed, and then obviously some of the delays were self-induced because they were afraid to come outside their homes and they weren't sure if the medical environment in particular was safe. Other patient factors were getting cardiac clearance. They couldn't get to another doctor because those offices were shut down. Wound infection. What if they had just had surgery in January or February? And then they were stuck with infection and had issues, and then there was delay in healing. And then maybe they needed additional imaging to get a better grasp of what their cancer situation actually was. You know, simple procedures like port insertions weren't happening. And then obviously financial. When someone loses their job, they also lose their benefits. And if they lose their benefits, they don't have money, an income, a way of getting health care, and potentially even a way to get to health care. So there were so many factors that we had to consider when looking at the delay of cancer therapy. But did it matter? Well, in the UK and Canada, where the government is controlling healthcare, they actually did a systematic review and a meta-analysis of about 34 studies. And throughout these studies, they were able to look at the impact of delays in 7 different cancer types: bladder, breast, colon, rectum, lung, cervix, and head and neck. And it turns out that the timing of treatment actually is very important, and the delays do matter. Specifically, some of the highlights from that study: the head and neck cancers, if there's a 4-week delay in radiation therapy, the death risk increased by 9%. In bowel cancers, a 4-week delay in surgery, the death risk increased by 13%. Imagine if you were a colorectal patient and you had a mass and you were about to have surgery, and if you didn't have surgery, you were going to have an obstruction. Think of the strain on the patient, and as far as like symptomatology, what could happen. Now there's even a death risk associated with that delay. And in breast cancer patients, an 8-week delay in surgery, the death risk increased by 17%. And if you just looked at a 2-week delay, it was an increase by 4%. There were all kinds of things that we as oncologists and cancer specialists were doing. We did neoadjuvant endocrine therapy while awaiting surgery. Up to 51% of cancer centers reported a change in treatment plans for chemotherapeutic agents, like taking dosing schedules and changing them. So FOLFOX, for example, that's normally given every 2 weeks, we would extend to every 3 weeks to decrease the touch points of the patient and for them to be able to stay at home. And up to 56% of oncologists reported a change in schedule for immune checkpoint inhibitors during the height of the pandemic. But it was nice to be able to do that with some data, that we could go from Q2-week dosing to Q6-week dosing without losing efficacy for our patients. We changed preference of treatment for an IV medication to an acceptable PO treatment, or an IV treatment to an acceptable sub-Q treatment. And fortunately, we had some of those options, and we probably collaborated more than we ever have in trying to help decide what we thought was best for our patients. 66% of radiation oncologists said existing patients had interruptions in their treatment, and we already know how important it is not to interrupt radiation therapies, but look at this, up to 45 days. You basically are starting over when you start again, right? In the United States, it was interesting, the University of Michigan actually created an app to calculate the risk of delaying cancer care during the pandemic, whether it was their surgery, their radiation, their chemotherapy. And this is not something that's out there now and available, but it was within a clinical trial, and it turns out that this app actually was very predictive, and we thought we were going to have to use it to convince the CDC and the government to let cancer patients proceed on with their therapy. And that's what a lot of this data was used for, just saying cancer can't wait and we need to keep going. What if the patient actually did get COVID? What happened? You can look at these CT scans and see that, what a COVID lung looks like compared to a normal lung. And imagine if metastatic disease was set on top of that, or imagine a primary lung cancer was set within that environment and how difficult it could be for the patient to recover. And it turns out that there's really a microenvironment that we're looking at as far as what is actually happening with our patients. So the National COVID Cohort Collaborative, say that 3 times, found about 400,000 adult patients with cancer from 50 medical centers out of 4 million patients that had had COVID. And the most common represented cancers were skin cancer, breast, prostate, heme, and GI cancers. And this study was really important because this was the first time that we started having risk factors within our cancer patient population and knowing who is at the highest risk of complications from COVID and who is going to have the bigger issues. So what this study found is that if you were over 65, if you're a male, Southern or Western U.S. residents, an adjusted Charlson comorbidity index score of greater than 4, and if you're not familiar with that, it's a score basically that is gives a 10-year survival prediction based on comorbidities. And just to give you an idea, if you are between 60 and 70 years old, you get 2 points, and if you have a solid tumor, you have 2 points. That's it. That doesn't, if you have diabetes, you get another one. If you have congestive heart failure, you have another one. If you have chronic kidney disease, you get another one. And so you can see how quickly it adds up. But just the factors of age and cancer alone on that comorbidity index score really was making a difference. Hematologic malignancies, this is where we thought all we needed to worry about was our lung cancer patients, right? But then we really realized that the heme patients they were really at high risk, and we needed to be careful getting them through their treatment. If someone had multi-tumor sites or metastatic disease, that was worse for them. And then if they had had recent cytotoxic chemotherapy, so traditional chemotherapy, like we've all grown up accustomed to, that's what increased the risk. Interestingly, immunotherapies or targeted therapies did not have a higher risk of overall mortality. So what happens? Why do these patients have a higher risk? Why do they die? Why is their mortality higher? And the bottom line is that cancer, as well as our treatments, oftentimes are associated with an increased likelihood of inducing certain cardiovascular complications in patients. And the combined effect of this with those associated with COVID could certainly be devastating. It's the double hit hypothesis. Some of the specific complications can be further exacerbated by COVID include blood stasis, vascular wall damage, and hypercoagulation states. And so if you already have a cancer that is increasing your risk of having blood clots, for example, like maybe a pancreatic cancer, then you're already at higher risk, have COVID on top of that, then the risk goes higher. Imagine certain therapies that we have, like tamoxifen or Revlimid, that we know the thrombotic risk is higher, then those are going to increase your risk if you put COVID on top of that as well. The exact mechanism of the synergies is not known, but it's been amazing what we can see on a cellular level, and I'll show you a picture of that in just a second. But really it's the hyperinflammatory reaction, and it's these two conditions combined that promote dysfunction in the cardiovascular system. The hematologic cancers in particular involve treatments that alter the function of normal B cells. So obviously immunity is attacked, and that becomes a problem for those patients because they don't have any ability to fight anything on their own. So this is really an interesting photomicrograph, and you can see the yellow outline. Those are small microvessels, and this gives you an idea of what is happening inside the microvessel. And there's a complex called a neutrophil extracellular trap. And on this photomicrograph, the neutrophil extracellular trap are the cells that look kind of brighter white. And you can see where the red are platelets that have accumulated, you see more of these net structures. And so we think the neutrophils are also playing a very big role in creating these microvascular thromboses. We talked about delays in treatment. What about delays in diagnosis? When everything shut down, nothing happened, right? Nothing happened. We didn't know. There were no screening tests. Anything that was non-emergent had stopped. So let's look at some of the specifics. If you look at the cancers that can actually be screened, we look at breast, cervical, colorectal, lung, and prostate. In breast cancer, there was an 87% decline in mammograms that were being performed. There was a 84% decline in cervical cancer pap smear screenings. Colorectal cancer, 80% decline in colonoscopies. Lung cancer, there actually wasn't much of a decline, but the reason there wasn't much of a decline is because we weren't doing much screening in the first place. So I think we've learned some lessons as far as that's concerned. And then prostate cancer, roughly 40% of PSAs had gone down. But what are the numbers? What does that really mean? Well, it looks like 3.9 million women missed their mammogram. 3.8 million people missed their colonoscopy. 1.6 million did not have a PSA that normally would have had those. It's interesting, geographic differences were observed in the Northeast that experienced the sharpest declines in screening, but that's also because they had the highest rates of COVID and they were closed for the longest time. And there was a slower recovery in the West when you compare that to the Midwest and the South. I said I wouldn't get political during this talk, but you can only imagine why that's probably the case. And if you look at socioeconomic status, this is also interesting. The largest screening decline was observed in individuals in the highest socioeconomic index quartile, which subsequently led to a narrowing of the disparity in cancer screening. But it led to the disparity because those that weren't getting screened continued to not get screened, and those that weren't. So the delta became a lot closer. It wasn't for the right reasons that the disparity gap was closed. So what do we anticipate because cancer screenings were delayed? You know, I think we're worried about what's to come. We know a delayed diagnosis is going to lead to a marked increase in the numbers of avoidable cancer deaths because we presume that we're going to be seeing cancer patients at much later stages where they may not be curable. And we're still working on the backlog, and it's just creating a vicious cycle. It got to the point where some patients aren't necessarily Now we've gotten to the point where patients aren't necessarily delaying their screening, they just missed it altogether. And so then they come to the next year and hope that nothing happened in the meantime. During screening, I'd be amiss to not mention this a little bit. So the COVID vaccine, one of the things that we found in women that started getting mammograms again once screening resumed, is that oftentimes we were seeing adenopathy or enlarged lymph nodes for patients that were getting their mammogram, and that was giving us sort of false positive results, presuming that there could potentially be a new cancer. So we've learned to even ask, and this is what our breast center does when patients are coming in for their screening mammograms now, have you had a COVID vaccine and when was it? Because we want to delay that screening a little bit so we don't get the false positives either. We want to make sure we can read a clean test. What about cancer research? You know, this was really interesting. Just on February 9th, the American Association of Cancer Research unveiled a report and did a panel discussion and virtual briefing. And if you have a chance to look this up, it's really fascinating and a great summary of what's happened to our cancer patients. But it's the report on the impact of COVID-19 on cancer research and patient care. And it goes through lots of different things, not just research itself. But COVID-19 interrupted all aspects of the cancer research and care continuum, all aspects. When we are in the clinic, we think about the clinical research that was missed. We know as clinicians that oftentimes our patients on clinical trials, the trials were closed to new enrollment, or certain things weren't able to be done because labs were closed and we were doing central testing. Well, I'll show you in a minute how this may change the landscape of research for our patients. But the loss of productivity was also noted in preclinical trials, right? In the laboratory activity, 66% of all labs actually completely closed. They lost their reagents. They lost their cell lines. They lost the mouse colonies. Those were things that, frankly, I had not actually thought about when we were talking about the changes in research. But and if those things don't happen, then you can't ever get to the clinical phase. We also had delays in reporting results of clinical trials, and then there was no sharing of information due to no conferences, no travel, people couldn't collaborate, and that really stifles research and progress. Interestingly, a lot of the cancer researchers were shifted to be COVID researchers. So they stopped their cancer research and went to COVID working on the vaccine because it was the decades of work that they had done on mRNA vaccines for cancer immunotherapy that paved the way for an unprecedented development of a COVID vaccine. So we are probably going to be redesigning the cancer clinical trial. Before the pandemic, you can see it was site-centric. Patient always had to come to the hospital, or clinic, everything was done there. And it was centralized labs, centralized testing, centralized imaging, radiology review that was centralized. But now we're going to look into the future and make it more patient-centric. Let the patient stay close to home. It's okay to maybe do remote patient monitoring through new techniques in telemedicine. It's okay to send the drugs to the patient and be able to monitor them now remotely rather than having them to come to the clinic to pick up every single pill. It's going to be, I think, a really interesting landscape to watch in the next few years. Here's where we started. This was February 1st, 2020. 12,000 COVID cases, 0 deaths. A year later, we have a pandemic and over 2 million people have died. A couple of weeks ago, nearly 6 million people have died, and you can see the worldwide pandemic and how prevalent things are. So what does the future hold? Now what? What do we do? I think that COVID will continue to change us. I think it'll continue to challenge us. And it's difficult and also dangerous to make specific predictions about biology and pandemics. The virus is becoming more endemic and less pandemic, and we'll slowly note a decrease in the daily pressures that the virus has caused. This battle is far from over, but despite multiple setbacks and a few major advances, I would venture to say we are winning. Why? Because we're all here today. And our presence means that we're winning. And we just have to remember that cancer can't wait. Thank you.